Jay, is it full screen now?
Yeah. Yeah, it is. You want to wait for a few minutes for people to come, or shall we start?
Sir, shall we start, sir?
I think so. No, otherwise, we won't finish.
Yes, sir. We'll start, sir.
Yeah, I think so.
Yes, sir. Good evening, respected Anil Karapurkar, sir, and my friends. Today's topic is carotid stenting. I'm going to give a general overview on how to do the procedure and what are the basic materials that we use in the procedure. I'm not going to go deep into what are the indications, what are the complications, and how you choose the patients. I'm just going to discuss about the materials in general that we use in the procedure. So, yeah. So, as any other procedures in medicine, carotid stenting has also gone through a lot of evolution, and in fact, actually is still evolving. So, just to come first, in 1976 and 77, there were like animal experiments that were being done to show artificial carotid stenosis and dilatation and cerebral perfusion. And at that time, in 75, there was a big uproar and controversy, and vascular surgery was so angry and upset and said that carotid bifurcation or carotids in general is a sacred territory and should not be touched, or stenting is not the ideal procedure and only endarterectomy should be done. And it took almost 13 years to come with NACET and ECST guidelines to say that in select patients, actually stenting works. And also in the same year, German Society of Vascular Surgery also raised an alarm saying that this procedure is completely has unacceptable risks of stroke and there is no alternative other than vascular surgery to touch the carotids. So in 1980, after that, the first patient where plasty was done rather than stenting, where this was a atherosclerotic disease patient, where angioplasty with 4 mm balloon and catheter shaft of 9 French was done with over the wire technique. And in 1989, the first patient with patient was stented. So from there, we have come a long way. So just I'll go through the steps of carotid stenting, and at each step I'll just explain what are the materials that we use. So generally, if at all you are doing through femoral or if at all you are doing through a radial access, first puncture and femoral puncture. Already Dr. Ahmed Zubair has gone through, explained us in detail about the puncture technique. So after the puncture, we take the diagnostic catheter into the aortic arch. And this was our patient which we did recently. So those are the images that I'm showing it to you. So we hooked the right brachiocephalic and took a roadmap. From there, we went into the CCA. So in this, there is no theory like one size fits all. So if at all on the left, you have a young patient where the carotid arch is really favorable, where it is exactly at 90 degrees and it is really easy for you to hook. Whereas if you see the arches on the right side, if at all you get a type 3 arch, or if at all the patient is very old and has a tortuous aortic arch and vessels, or in a arteriosclerosis patient where it is very high, not favorable and it is an acute angle. So then different catheters according to the anatomy of the aortic arch you can choose. Either you go for a Picard, Headhunter, or sometimes Simmons catheter. It completely depends upon which side you are dealing with and what type of arch you are dealing with. And on the right, it is a coaxial system where you take the catheter, diagnostic catheter, along with that a guide sheath or a guiding catheter, and along with that a wire, where the guiding catheter provides a slight bit more support so that it helps us to go up into the CCA. So it completely, as our mentor, the GG sir tells us, 90% of the thing about neuro intervention is about planning and only 10% is execution. So it's always better to look at the MR angiogram or the CT angiogram if at all it is done, and to look at the arch and to select the catheter. So after that, once you have taken the diagnostic catheter, now our thing is to go into the CCA along with the diagnostic catheter and then take the wire into the ECA. So the guide wire which we use is the steerable 0.35-inch wire selectively into the external carotid artery. And as a rule, the wires are generally relatively rigid. So they need good support from the cerebral catheters in especially angled or elongated carotids, so that they compensate the force vectors which are generated generally when you push the wire. So the steerable wire generally, if at all you don't have adequate backup, will generally fall back into the aortic arch. And this kind of guide wires, what you're looking for is a good torque, because when you want to enter into the ECA, you have to negotiate so that it does not enter into the internal carotid and you poke into the clot, so that it should have a good torque. And also it should be a floppy and non-traumatic tip, so that it does not damage the vessel or it does not cause any embolization. So this is what you expect from a guide wire, and we generally use a 0.35 guide wire. We, in this case particularly, or generally we use a radio focus. And guide wire properties, there are 2 to 3 types of guide wires. One is a Teflon coated steerable wire, and second is a hydrophilic coated steerable guide wires. But Teflon coated generally is a wholly high torque which is commonly used. The main advantage of this wire is it has a good torque, and it also has a soft tip which generally avoids plug dissection or disruption. But also it has a disadvantage in that it provides poor support, which is insufficient in most cases. Otherwise, you cannot progress the guide catheter along with it or over it. Generally, we use hydrophilic coated steerable guide wires, and this particularly was a glide wire, thermo glide wire 03, and in some cases also road runner. But the main advantage in this is, being glide, it has good friction reduction and also has a good torque control. And second thing is coming to the extra support exchange wires. So once your wire enters into the ECA, the main thing is you need a good exchange wire. And also the property of guide wire is you need a wire, because you are taking the wire into the ECA. Sometimes you should avoid going into small vessels because it may puncture the small vessels. So you also, guide wire needs to have that property. So generally, in this case, we used a Terimo exchange wire, or else there are other types where 0.35-inch Amplats super stiff and also Amplats ultra stiff flex tip wires. Both guide wires were designed with a short and a long distal flexibility. Generally, long flexible is helpful because to avoid artery wall injury, and also short tip generally provides some artery damage. So on the left you have where we have the guide catheter parked in the CCA, distal CCA, and we have a wire crossing the stenotic segment, and going in. Then we have passed the micro wire, and after that we place a balloon for plasty pre-dilatation. Well, I'll just come to the materials. So you can use a guide catheter of your choice, generally Neuron Max, Cerebase, or Ballast, or NY, depending upon whether you are using a radial puncture axis or whether you are taking a femoral axis, and depending upon the arch and your carotid tortuosity, you can select the guide catheter of your choice. So the important thing you should note is, when the guide and sheath should have a good relationship with the inner device, because in the guide catheter you are going to put the device, whether that be a balloon or whether that be a sheath. So it should be able to go inside, and also you should be able to negotiate and track it properly to the place where you want to put it. So generally the catheter and their relationship with the device should be, when you use a 4 French device, better to have a 6 French guiding catheter, or vice versa, 5 French, 7 French, 6 and 8, 7 and 9, and so on. And in case of sheath utilization, the diameter of the devices should be 1 French minus. That is, if at all you have a 7 French sheath, you take over a 6 French device. And also the preferred length is 90 centimeters, which is enough for the deep cannulation of the carotid, which allows a 100 or 120 centimeter long diagnostic catheter inside to come out at its distal tip. And angioplasty wire, this is the micro wire which we pass. This also should be very floppy, because this is the first wire which you are going to introduce across the lesion. So if at all it has a floppy tip, you can negotiate it very easy, and it does not cause embolization. So extra support wires such as Roadrunner 018 can also has an advantage in severely tortuous or angled arteries, for which progression of balloons and stents over them can be difficult. So next, coming to the balloons. So generally we use the coronary balloons, and in this particular case we used a 2.5 into 4 balloon, and generally 30 to 40 mm long monorail with a 3.4 into 4 mm diameter for pre-dilatation is the routine. It's completely operator dependent, where they use different balloons, and post dilatation is necessary sometimes to match the stent diameter with the artery diameter. Sometimes people say pre-dilatation sometimes, so this is a controversial area. A mean diameter of the internal carotid generally is about 5 to 6, and common carotid is 8 to 9. So new generation of monorail low profile large balloon diameters are actually available. When over the wire balloons are used, they must be large enough to reach the lesion through the guiding catheter. So generally 135 centimeters or longer. That we should always make sure before the procedure. So in this case, it is post balloon dilatation. We have now introduced the stent, and after that we are post dilating it with a balloon. This is a post plasty image, and after plasty we have deployed a stent and dilating it post dilating. So this is the stent deployment. You see the initial part coming out, and then the full stent is deployed. Sorry, this is the post dilatation, balloon dilatation. And coming to the stent, now we'll discuss about the stent set, different embolization, embolus protection devices. So generally, what is an ideal stent? What characteristics should it have? So it should have a longitudinal flexibility, because it should follow the tortuosity of the vessels during deployment, and it should have a good scaffolding so that it should support the carotid shape, and it should also have a coverage which should hold the atherosclerotic material, which generally avoids the distal embolization. It should have adequate radial force, and it should have enough resistance to external compression and arterial elastic recoil. It should be very elastic. It should be able to conform to the diameter of the vessels, and it should have a good opposition, that is contact with the arterial wall. It should have a good radio opacity so that you know where exactly you are placing the stent, and it should have a precise deployment where it ensures the final position of the stent in relation to the bifurcation and branches. So these are the ideal characteristics which you look for in a stent. And we have gone through different stent materials over the period of time, where we started with stainless steel stents, which have good high strength and radial force, but they have low MR compatibility and bad vessel wall stent opposition. Now generally we use, most of the vessels that we use generally are nitinol made, where they are very super elastic and they have a good memory property and biocompatibility. And the disadvantage is they have a weak radial resistive force and low radio opacity. And also, sorry, apologize for the sound. And also, the nitinol stents have low radio opacity and tend to fracture. And there are some drug-eluting stents which reduce the restenosis rate, which still are not in use. Only clinical data is present, and future still experiments are going on polymer stents. So you can divide stents on basis of whether they are straight or whether they are tapered, or one division or differentiation can be a closed cell and an open cell. You can see in the closed cell where the lattices are very close together and the struts, whereas in the open cell you see the struts are far apart and there is no the lattices are not close together. So what are the advantages of closed cell is it has better lumen to plug barrier and there is no stunt protrusion because they are very close together. And the disadvantages are it has a tendency of possible kinking and it has the issue of deliverability. Whereas in an open cell, it has a good coverage and it is easily deliverable and it has a good wall opposition and a good radial force. But the disadvantages are strut protrusion and there is a chance of balloon rupture. And also there is a chance of plaque protrusion and embolization. But also the closed cell potential use is you can use it where you feel there is high risk for embolization. But whereas in open cell, you can use it in carotids which are you have tortuous anatomy. In those kind of cases, open cells would be better. Open cell stents would be better. So as I was telling you, this was the open cell stent and this is a closed cell stent. This would be slightly rigid, so will be less favorable in a tortuous vessel, whereas in this it will be favorable, open cell will be favorable in tortuous anatomy. So again, comes reiterating the same point, the disadvantages of closed type, because it is very rigid, it is less conformable in tortuous vessel. Whereas the advantages are it has a better, I mean, it has a better scaffolding effect, whereas it also decreases distal embolization. Whereas in open type, the advantage is it can navigate through torsional vessels and it has avoids arterial kinking due to unnecessary vessel straightening. And the disadvantage is due to increased area between the stent lattices, these stents do not exclude the plaque as well as their tightly woven counterparts. And this is one of the hybrid type crystalloideal where middle part, I mean the distal parts are tapered and the center part is closed type, whereas the distal parts are open type. The advantages with this is the proximal part you can put it in the straight segment of the ICA and the distal part you can put it in the ECA, and in the closed cell type you can put exactly at the bifurcation where the plaque will be completely embedded into the closed type, which will also reduce embolization. So this is the hybrid type where you have both open type and closed type both in the same stent. Whereas if you see in the stents which we commonly use, the proximal part would be straight type and the distal part would be tapered, and the whole stent will either be a closed type or either will be open type. So coming to few of the commonly used stents, carotid stents, this is one of the C-guard, which is made of nitinol, and this is an open type where it has a dual layer design. If at all you see it is an open type, but you have a layer, you have a mesh on top of it. So it combines the open cell frame and also it is embedded with a mesh which has small pores in it. So it is called the micronet, which prevents plaque protrusion through the stent. It comes in lengths of 20, 30, 40, 60 and with a diameter of 6, 7, 8, 9, 10 mm. So the advantage with mesh is few people are not using nowadays embolic EPDs because it also has a mesh which prevents further distal embolization. So it prevents both. It gives you additional where it forms the coverage of the plaque also, and it prevents distal embolization also. And this is exact where it is nitinol constructed, and if you see in the diagram where distal part is 6 mm which goes into the ICA and 8 mm the proximal part is 8 mm which goes into the ECA. sorry, the proximal part goes into the CCA, which is slightly bigger than the ICA, and the distal part 6 mm goes into the ICA. So it has straight and tapered stent configurations and minimal foreshortening. And this is the stent which has maximum radial force at the lesion. And it has increased stent coverage at the lesion designed to minimize plaque extrusion and minimizes risk of snagging. And the third type, in this particular case, we use a Protege RX, which is an open type and which is made of nitinol, and its unconstrained stent diameter is 5 to 10 mm and its unconstrained length diameter is 20 to 40. This is again a open type. So this is again a newer generation or the next generation carotid stent, Gore carotid stent, which is again an open cell nitinol frame and which has a 500 microns lattice on outside of the frame. The mesh, if you see, that is the pores are 500 microns. It gives a high flexibility and conformability and which reduces plaque prolapse and amount of emboli, which are released during and after stent deployment. And the other type is called road saver, which is from Terumo. The only difference is it has a closed cell, whereas Gore and Seaguard are open cell nitinol frames, but whereas road saver is a closed cell nitinol frame with again a inside nitinol micro mesh. So these are next generation stents which have dual layer designs where they have a open or a closed layer design along with a mesh, which is predominantly designed to avoid distal embolization. So these are open versus closed stents where you have Aculink, which is again an open cell, and here are the free cell area, that is even in closed or open you have the area which is free cell area. So Adapt, Cristallo Ideal, which I was telling you, which is a hybrid which has both open and closed in it, and Gore, Road Saver and Inspire Seaguard are the mesh covered stents which have the mesh on top of them. So how do you select a stent? It should be predominantly dependent on the grade of tortuosity. So if at all you have a grade 1 or 2 tortuosity, then you take the patient. It's not ideally done, but if at all you can do a carotid Doppler, then you can see the lucency of the plaque. There is something called grayscale median. So if at all, by this you can grade the lucency of the plaque. In symptomatic patient with an echolucent plaque or the grayscale median less than 20, then it is always better to select a closed cell stent because it has higher chances of distal embolization. Whereas in an asymptomatic patient where there is a less area of plaque distal embolization, either stent you can choose. Whereas in a grade 3 tortuosity, it is always better to select a open cell type. And always when choosing a stent, you should always see the embolic potential of the plaque and you should always see the carotid tortuosity should be considered. So pre-procedural, generally in few centers they do carotid Doppler and identify friable plaques and assess risk and see that whether they are choosing a closed cell stents. And if at all, if you see the lucent area, echolucent plaques are having high risk of distal embolization. In those types also, you should always make sure you are choosing a closed cell type of stent. And there is a grading of carotid tortuosity. If at all you have done a MR angiogram or a CT angiography, you draw a center line on the arch and from there you calculate the angle, and if at all it is less than 30, grade 1, 30 to 60, grade 2, and if at all it is more than 60, it is grade 3. As I was telling, grade 3 open cell types are better, and grade 1 to grade 2 always closed cell types are better. So where and how to deploy the stent? So you should see that the distal end of the stent has to be deployed from within the healthy part of the internal carotid artery. And it is not significantly important where the proximal end of the stent is located in the common carotid. The unconstrained diameter of the self-expanding stent to be deployed should be at least 1 to 2 mm larger than the largest vessel segment to be covered. And the length of the stent depends on the length of the stenosis being either ranging from 20 to 40. And always try to avoid placing the distal end of the stent into kinks or tortuosities of the ICA. An important technical point is to release 3 to 5 mm of the stent distally and wait for the stent to expand fully and stabilize against the vessel wall before releasing the remaining of the stent. And all of the nitinol stents have the tendency to jump distally if released too far. So you should always be careful and release slowly and make sure initial part has expanded before releasing the remainder of the stent. And some of the newer stents need only six French delivery system, and it is always safer to underdilate than overdilate the self-expanding stents. And overdilation with high pressure squeezes the atherosclerotic materials through the stent mesh, causing emboli. And it is not necessary to dilate the stent to obliterate segments of the contrast-filled ulcerations or part of the bulb external to the stent. So these parts are always very crucial when deploying the stent. So there are certain studies where they have there is a way of measuring the length of the block, but it is very difficult. It only helps you to choose what length of stent that you choose. So one way is measuring the length of the block on the top and also at the lowest diameter of the block. There are 3 ways which we have described, and depending upon the block size, you can choose the stent. So coming to the protection, embolus protection devices. So 3 are explained, where if you see the lower diagram, we dilate a balloon distal to the block. The only problem and disadvantage, the advantages is it prevents embolus from going distally, but the problem is the disadvantages are complete occlusion of the ICA can be dangerous sometimes with insufficient cerebral collateralization. And also one more disadvantages is it gives you, sometimes you cannot assess the target lesion if at all you are completely occluding the balloon. And third thing is, if at all you are over dilating the balloon, it always can be dissect or cause rupture of the vessel. So this is the distal occlusion balloon, where it is distally balloon is occluded and there is an aspiration catheter which aspirates the emboli that has gone distally and which is before just prior to the balloon. And these are the proximal occlusion devices, where a balloon is put in ECA and where it is occluded, and when one balloon is there in the ICA which is occluded, which generally work on the principle just exactly like what they do in endarterectomy, where they have clamps in the ECA and the ICA, and where they cause the reverse flow pattern within the ICA, thereby preventing the embolization to the brain. So again, sometimes it can cause hypoperfusion and sometimes can cause problems. So this is another proximal occlusion devices. And the third variety which is commonly used is the distal filter protection devices, where you put a filter distal to the block and generally all the debris is collected in the filter and thereby you remove the filter. The side effect disadvantages with filter is sometimes it can cause dissection, or sometimes you have debris collected at the edge of the filter, which can, after removal of the filter, can again go distally. So that is one problem with filters, and the commonest is causing dissection or sometimes spasm of the vessels. So these are the different types. One is, if you see on the left side, you see the filter placed with a wire, and sometimes if at all you are using a filter, you don't need to use a micro wire which you insert, angioplasty wire. This itself serves the purpose. So where you put the wire and the filter is opened, and all the debris is collected, and then the filter is closed and the wire is removed, where the filter comes along with it. So one type is the AngioGuard XP, which you can see is the filter here. And second is the filter wire EX from the Boston Scientific. And these are here you see the Spider RX filter, which is commonly used nowadays. This is the AccuNet filter wire AngioGuard, different types of EmboShield Pro filter, different types of filter devices which we use nowadays. And these are few commercially available filters where the characteristics are there. Spider RX is generally used the filter nowadays. Thank you. This is the brief description about the materials, stents we use, and the filter devices that we use. I've not gone into the complications which are pre-procedure, post-procedure, like hyperperfusion syndrome, or distal embolization, or hypoperfusion, or asystole. All this or the guidelines to the procedure. I have not gone into them. I have purely stuck on to the materials.
Thank you, Dr. Sagar. You covered the material that's mentioned quite well. I may add a few things to what you have said.
Yes, sir.
One is, you mentioned the femoral access. There are two ways to do it.
Yes.
When I started in 1997, always used to use a short sheet and a guiding catheter.
Yes, sir.
And the guiding catheter that I used initially in the beginning was a 9 French GR4.
Okay, sir.
Later, when the 8 French straight catheter, guiding catheter became available, that is the one that I was using. That was my favorite. It was very good. The advantage of a straight catheter is that it stays straight in the middle of the lumen.
Yes, sir.
It is not available just now, so we have started using the MP. The disadvantage of MP is that it strikes the wall.
Yes, sir. Yes,
so
sir.
when your device is coming out, it may strike the wall and you may have to adjust a little.
Yes, sir.
But this is the long sheet. I mean, this is we use the guiding catheter.
Yes, sir.
And the guiding catheter should not be less than 8 French.
Okay, sir.
So when they say 6 French, it is a 6 French sheet.
Yes, sir.
Not a 6 French guiding catheter. You
Yes,
have to
sir.
remember that, and everyone
Yes.
should remember that.
Yes, sir.
So, though they may say 6 French compatible,
Yes,
one
sir.
should always look at the OD of the device which is going inside and the ID of the device outside.
Yes, sir.
Because some OD, some guide catheters have an ID of 5.6, some have 5.2, some have 5.8. So
Yes, sir.
they are all 5F. So always check the ID of a device before you start.
Yes, sir.
Second is, often we use a guiding catheter. By we, I mean neurointerventionists.
Yes,
But
sir.
if you speak to the radiologist or to the cardiologist, they
Yes.
use a long sheet.
Yes,
And
sir.
in between, when we did not have a guiding catheter, we were using a long sheet.
Yes,
So the
sir.
advantage of a long sheet is it gives you very good supply.
Yes, sir.
But what we do is, in a tortuous, so you access with a 5 French,
Yes,
and
sir.
then you go with a long sheet inside.
Yes,
So
sir.
the long sheet gives very good supply.
Yes.
For us, a 6 French or a 7 French long sheet, which is 70 or 80 centimeters long, is good enough. If we use too long a sheet, then again it is a problem. So we have to use a long sheet. The 6F long sheet can go through an 8 French femoral sheath.
Yes,
So
sir.
you can still use a 6F long sheath through an 8 French. But if you use an 8 French long sheath, then
Yes,
you have
sir.
to go through the groin, exchange, take the short sheath out, and bring the long sheath in.
Yes, sir. Yes, sir.
Now, many times, no matter how careful you are, air bubbles form in the hub of the long sheath. So
Yes, sir.
what we usually do is, we don't connect the irrigation system to the long sheath. We always
Yes.
go in with everything disconnected and aspirate, so that
Yes.
if there's any air will suck it out. Or we exchange in the descending aorta.
Yes, sir.
Second thing is, when we talked about exchange,
Yes,
we
sir.
said exchange terumo and exchange implants.
Yes, sir.
I find exchanging with the terumo is difficult. It's a very slippery wire.
Yes,
It
sir.
comes out very easily.
Yes, sir.
So to exchange, I always use the regular, not the implant, the regular terumo wire. So once you got your catheter 5 French into the common carotid, you bring in the Teflon regular 38 wire. It gives
Yes.
enough support to advance the 5F to 8F or 6F to 9F.
Yes, sir.
Baby and mother, we call it baby mother, so that you don't injure the artery, so that if there is a shelf,
Yes, sir.
it won't get dissected. So you should always have you should not advance the 8F on the wire alone.
Yes, sir.
It should be with a catheter inside.
Yes, sir.
And for that we can use, for the right side it doesn't matter, but sometimes for the left side, it might be better to use a
Yes, sir.
125 centimeter catheter instead
Yes,
of
sir.
the regular 100 centimeter catheter.
Yes,
So
sir.
we access with the 5 French 100 centimeter, but when we are exchanging, we usually exchange with the 125.
Okay.
And that 125 can be a JR4 or an MP, it doesn't matter.
Okay, sir. Yes, sir.
So these are some of the things that I thought are for especially those who are starting or those who are beginning, might
Yes, sir.
be useful. So a lot of people use the long sheath, and we also have used the long sheath quite comfortably.
Yes,
The
sir.
advantage of a long sheath is it gives you a very good lumen and very good support.
Yes, sir.
Especially if the anatomy is very tortuous, like you showed some very tortuous anatomy.
Yes.
Then about the stents, you mentioned, so we always measure the diameter of the common carotid,
Yes, sir.
not the internal carotid.
Yes,
It's
sir.
always the common.
Okay,
If
sir.
there is a big discrepancy, usually these self-expanding
Yes,
open to the cells of the artery.
yes,
So
sir.
in a internal carotid, it may be half the size of the common carotid or smaller than that. The stent gets elongated, especially the wall stent.
Yes, sir.
The nitinol stents don't get so much elongated. The
Yes.
foreshortening is only about 10 mm,
Yes, sir.
10%. But
Yes,
in
sir.
a wall stent, the foreshortening or long, if it is a big artery, it gets foreshortened.
Yes,
If
sir.
it is a small artery, it gets elongated.
Yes, sir.
So you have to be, especially with the wall stent, be careful about that.
Yes, sir.
So to overcome this, some people are worried about having stent. So that's why they have that tapered stent.
Yes, sir.
You mentioned that tapered stent.
Yes, sir.
So tapered stents are of two kinds.
Yes,
The
sir.
Abbott tapers progressively.
Yes, sir.
The protege has a shoulder.
Yes, sir.
So you have to get that shoulder. So it's 8 French and then 6 French.
Yes,
There
sir.
is a shoulder.
Yes,
You have
sir.
to get that shoulder where the artery becomes narrow. That is
Yes.
the difference between the protege and the tapered Boston, not Boston. Which stent is that? Abbott stent.
Yes, sir.
Yeah. So they are tapered like that, progressively tapered. And what else shall I say? Materials wise, you mentioned Terumo stent. Actually, it is a microvention stent, and it is a double layered stent. It is called Casper. CASDR, but we have not yet used it in India because their price is very high. But it is a double layered stent.
Yes.
There is no mesh inside. It is both similar stent made of nitinol. Both layers are nitinol.
Yes, sir.
So they say that the chance of embolism through we call it the greater cheese effect is much less with this. Similarly, the C-guard is used essentially where you suspect that there is a lot of debris which can go up into the cause embolism.
Yes.
I think that's all that I would say. But you have covered the subject quite well. You have covered almost everything. So I think we'll have to stop now. So thank you very much.
Sir, one doubt, sir, actually, regarding using a protection device and doing stenting without protection device. Now with this...
that debate will always go on. All over the world, there are people who use a protection device. There are people who don't use a protection device. I did not use a protection device from 1996 to 2007. 2007, we used a protection device in a patient who had, in fact, in that patient who did not need to pre-dilate. It was a 70% stenosis patient was symptomatic. But the last TIA was more than 2 months earlier. But even then, that was the first patient that I used a filter, and we found debris inside the filter. So having seen that, we use a filter every time, except if the artery is very tortuous beyond the disease, and there is no what we call landing zone. The filter has to have a landing zone.
Yes.
The disadvantage of the spider is it is a long filter. The other one that you showed, Angioplasty, it is a short filter. Even the other one, the Abbott filter, that is quite bulky. So due to the tight stenosis, it is not easy to cross. The best, lowest crossing profile is that of spider. There is no question about that. But the spider does not absolutely completely hug the wall. It has to hug the ring, has to hug the wall of the carotid. It does not, especially at the bends, it does not do that. The angioguard, on the other hand, does it very well. Even the NAV7 or the Abbott, that one also hugs the wall very well. So embolism with that is much less. And if the artery is very tortuous, you may be able to deliver. Even delivery may be difficult. For retrieval is even more difficult. So for retrieval, sometimes we have had to, especially in a calcified artery, and if you use an open cell design, sometimes the filter can get stuck. Sometimes we have to turn the head to one side, turn the head to the other side, flex, extend. Or sometimes we have taken the guiding catheter inside the stent to be able to get there. So you have to look at the landing zone. I think the landing zone is very important, and how heavy is the calcification of the stent, of the artery, of the plaque. How heavily calcified, especially if it is a circumferential calcification, the stent may not open. So then you may have to go up on the balloon.
Yes.
So, and one more thing is, we have seen bradycardia and hypotension, which is very severe with the post-dilatation, especially in patients over the age of 70. So sometimes the patients have had bradycardia also going to 40, 35, 36, 25, and we have to live atropine or albumin. But since we have almost reduced our post-dilatation, we don't see that so much. Hypotension, rarely we have had to use NORAD, and in some patients we have had to use NORAD for 2 or 3 days for because of persistent hypotension. Patients, especially if they have coronary artery disease, if they have coronary carotid disease, then we may have to use all these things, NORAD and alpha blocker.
So post dilatation not necessary, sir.
No. If there is a persistent notch,
Yes.
then we have to do it. Sometimes the plaque is very hard and the stent does not open, or sometimes it is calcified. Then you have to do it. But you don't go overboard. Just one little bit and then stop. So we don't try to, that's not like the cardiologist get a perfect alignment. And this is essentially when you are at the carotid body. If you are above or below, it doesn't matter. At the carotid body is where it causes the problem.
Sure. Thank you, sir.
Any more questions from anybody or any comment from anybody else? You can unmute yourself and okay. I think there are no more questions, so I think we can stop. Thank you very much.
Thank you very much, sir. Thank you, sir. Good night, sir.